Hello everyone, welcome to another pediatric lesson. In my today's talk, I'm going to discuss about juvenile idiopathic arthritis in children. Juvenile idiopathic arthritis is the most common rheumatic disease in children and one of the more common chronic illness of childhood. GIA represents a heterogeneous group of disorders sharing the clinical manifestations of arthritis, and the etiology and the pathogenesis of GI are largely unknown, and the genetic component is complex, making clear distinction among various subtypes difficult. As a result, several classification schemes exist, each with its own limitation. The formal classification of the American College of Rheumatology uses the term juvenile rheumatoid arthritis, and it categorizes the disease into three subtypes. In order to standardize the nomenclature, the International League of Association for Rheumatology proposed a different classification using the term juvenile idiopathic arthritis, inclusive of all the subtypes of chronic juvenile arthritis. So, in my today's lesson, I refer to the International League of Association for Rheumatology classification. To diagnose juvenile rheumatoid arthritis or juvenile idiopathic arthritis, the age of the child should be less than 16 years, and there should be an arthritis. Arthritis means swelling or effusion or the presence of limitation of range of motion, tenderness or pain on motion, and increased it in one or more joints. And also duration of this should be greater than 6 weeks. Otherwise, if the duration of the illness is not greater than 6 weeks, it is not juvenile rheumatoid arthritis. And also, if the age of the child is not less than 16 years, it might be adult type, it is not juvenile. And also, onset type defined by type of articular inflammation in the first 6 months after the disease onset. If the disease involves greater than or equal to 5 joints, we call it polyarthritis during the first 6 months of onset. And if it involves less than 4 joints during the first months of this onset, we call it oligoarthritis. And if arthritis occur with rash and the characteristics quotidian fever, we call it systemic onset disease. Quotidian fever is defined as fever that rises greater than 39 degrees Celsius once daily and returns to 37 degrees Celsius or below that between fever peaks. And also exclusion of other forms of juvenile arthritis needed. So it is a diagnosis of exclusion. Arthritis in greater than or equal to 1 joint with or preceded by fever of at least 2 weeks in duration that is documented to be daily or quotidian, as I have said above, for at least 3 days and accompanied by one of the following, such as evanescent or erythematous rash, generalized lymph node enlargement, and also hepatomegaly or splenomegaly or both, and also serocytes. So if there is one or more of those 4 criteria, and also fever for at least 2 weeks with which is quotidian type, it defines systemic GIA. And when we say about oligoarticular GIA, arthritis affecting 1 to 4 joints during the first 6 months of disease. So the arthritis should involve less than 4 joints, less or equal to 4 joints during the first 6 months of disease. And also 2 subcategories are recognized for oligoarthritis: persistent oligoarthritis and extended oligoarthritis. If the affected joint becomes greater than 4 joints after the first 6 months of disease, we call it extended oligoarthritis. If the affected joint remains less than 4 joints throughout the disease course, we call it persistent oligoarthritis. When we define polyarthritis, it is classified into two: rheumatoid factor negative and rheumatoid factor positive. Rheumatoid factor negative polyarthritis is defined as arthritis affecting greater than or equal to 5 joints during the first 6 months of disease, and a test for rheumatoid factor is negative. And we say rheumatoid factor positive polyarthritis if arthritis affects greater than or equal to 5 joints during the first 6 months of disease, and greater than or equal to 2 tests for rheumatoid factor at least 3 months apart during the first 6 months of disease are positive. We say psoriatic arthritis if there is arthritis and psoriasis, or if there is arthritis and at least two of the following: dactylitis, nail pitting, and ankylosis, and also psoriasis in the first degree relatives. We say enthesitis related arthritis if there is arthritis and enthesitis, or arthritis or enthesitis with at least two of the following: presence or history of sacroiliac joint tenderness or inflammatory lumbosacral joint pain, or presence of HLA-B27 antigen, onset of arthritis in a male greater than 6 years old, or if there is acute anterior uveitis, and also if there is history of ankylosing spondylitis, enthesitis related arthritis, sacroiliitis with IBD or Ritter syndrome, or acute anterior uveitis in the first degree relative, we say enthesitis related GIA. The final one is undifferentiated arthritis. This one is defined as arthritis that fulfills criteria in no category or in greater than or equal to two of the above categories. When we came to the epidemiology of GIA, the worldwide incidence of GIA ranges from 0.8 to 22.6 per 100,000 children per year, with prevalence ranges from 7 to 401 per 100,000. This wide range numbers reflect population difference and also particular environmental exposure and immunogenetic susceptibility, along with variation in diagnostic criteria and also difficulty in case ascertainment and also lack of population-based data. Oligoarthritis is the most common subtype. It is responsible for 40 to 50% of GIA. This is followed by polyarthritis. That's responsible for around 25 to 30%, and the systemic GIA accounts for 5 to 50%. But more girls than boys are affected in both oligoarticular and polyarticular GIA, and the peak age of onset is 2 to 4 years for oligoarticular disease, and the age of onset has a bimodal distribution in polyarthritis, with a peak at around 2 to 4 years. And also the second one around 10 to 14 years. And systemic onset GIA occurs throughout childhood and with a peak at around 2 to 5 years of age. When we see the etiology of juvenile idiopathic arthritis, the etiology and the pathogenesis of GIA are not completely understood, although both immunogenetic susceptibility and external trigger are considered necessary. Twin and the family study suggest a substantial role for genetic factors. And GIA is a complex genetic trait in which multiple genes might affect disease susceptibility. Variants in major histocompatibility complex class 1 and the class 2 regions have indisputably been associated with different GIA subtypes. And also possible non-genetic triggers include bacterial and viral infection, and enhanced immune response to bacterial or mycobacterial heat shock proteins, and also abnormal reproductive hormone levels and the joint trauma. When we came to the pathogenesis, GIA is an autoimmune disease associated with alteration in both humoral and cell-mediated immunity. T lymphocytes have a central role, releasing pro-inflammatory cytokines, favoring a type 1 helper T lymphocyte response. And the study of T cell receptor expression confirm recruitment of T lymphocytes specific for synovial non-self antigens. And the B cell activation and also immune complex formation and the complement activation also promotes inflammation. Inheritance of specific cytokine alleles may predispose to upregulation of inflammatory networks, resulting in systemic disease or more severe articular disease. Systemic GIA is characterized by dysregulation of the innate immune system with lack of autoreactive T cells and autoantibodies, and it might be more accurately classified as autoinflammatory disorder, more like familial Mediterranean fever, and more than that of GIA. It acts like familial Mediterranean fever. This theory is also supported by work demonstrated similar expression patterns of phagocytic proteins in systemic GIA. All these immunologic abnormalities cause inflammatory synovitis, characterized by pathologically by venous hypertrophy and hyperplasia with hyperemia and also edema of the synovial tissue. Vascular endothelial hyperplasia is prominent, and it is characterized by inflammation of mononuclear and the plasma cells and also with predominance of T lymphocytes. Advanced and uncontrolled disease leads to pannus formation, progressive erosion of articular cartilage, and also contagious bone. When we see the clinical manifestation of GIA, arthritis present, it is must for arthritis to be present, and the arthritis must be present for greater than 6 weeks to make a diagnosis of any GIA subtypes. And arthritis is defined by interarticular swelling or the absence of the presence of greater than or equal to 2 of the following signs: limitation range of motion, tenderness or pain on motion, and also worms. And initial symptoms might be subtle or acute and often includes morning stiffness with a limp or gelling after inactivity, and easy fatigability and also poor sleep quality might be present. Involved joints are often swollen, warm to touch, and uncomfortable on movement or palpation with reduced range of motion, but usually they are not rheumatas. Arthritis in large joints, especially knee, accelerates linear growth and causes the affected limb to be longer, resulting in discrepancy limb lengths. Continued inflammation stimulates rapid and premature closure of the growth plate, resulting in shortened bones. As we have said, oligoarthritis is defined as involving less than or equal to 4 joints within the first 6 months of disease onset, and often only a single joint is involved. And predominantly it affects the large joints of lower extremity such as the knee and the ankle, and isolated involvement of the upper extremity large joints are less in oligoarthritis. And those in whom disease never develops in greater than 4 joints are regarded as having persistent oligoarticular GIA, whereas evolution of the disease greater than 4 joints after 6 months changes the classification to extended oligoarticular GIA and is associated with a worse prognosis. Isolated involvement of the hip is almost never present in oligoarticular GIA, and it suggests non-rheumatoid causes, and the presence of positive anti-nuclear antibody tests confirms increased risk for asymptomatic anterior uveitis requiring periodic slit lamp examination. So if a patient have positive ANA, they are at risk for asymptomatic anterior uveitis, and they require strict periodic slit lamp examination with ophthalmologist. ANA positivity may also be correlated with younger age at disease onset and female sex, and also asymmetric arthritis and fewer involved joints over time. When we see polyarthritis is characterized by inflammation of 5 or more joints in both upper and lower extremities, and rheumatoid factor positive polyarthritis resembles the characteristic symmetric presentation of adult rheumatoid arthritis, and rheumatoid nodules on the extensor surface of the elbow, spine, and over the Achilles tendon usually they are unusual, are associated with more severe course, and almost exclusively occur in rheumatoid factor positive individuals. Macrognathia reflects chronic temporomandibular joint disease, and also cervical spine involvement manifesting as decreased neck extension occurs with the risk of atlantoaxial subluxation and a neurologic sequel. And hip disease might be subtle with finding of decreased or painful range of motion on examination. Bone mineral metabolism and skeletal maturation are also adversely affected in children with GIA, regardless of the subtypes. And children with GIA have decreased bone mass or osteopenia, which appears to be associated with increased disease activity. And also abnormality of skeletal maturation become most prominent during the pubertal growth period. When we see systemic GIA, systemic GIA is characterized by arthritis, fever, rash, prominent visceral involvement including hepatosplenomegaly, lymphadenopathy, and serocytes. The characteristic fever defined as spiking temperature to greater than 39 degrees Celsius, and it occurs on a daily or twice daily basis for at least 2 weeks with the rapid return to normal or subnormal temperature. The fever is often present in the evening and is frequently accompanied by a characteristic faint erythematous and macular rash. The evanescent salmon-colored lesion, classic for systemic onset GIA, are linear or circular, and they are usually distributed over the trunk and proximal extremities. The classic rash is non-pruritic and migratory with lesions lasting less than 1 hour. And the Kovner phenomena, a cutaneous hypersensitivity in which classic lesions are brought on by superficial trauma, is often present. Heat can also evoke a rash. Fever, rash, hepatosplenomegaly, and lymphadenopathy are present in more than 70% of affected children with systemic onset GIA. Without arthritis, the differential diagnosis includes episodic fever, infectious causes such as endocarditis or acute rheumatic fever, and also other rheumatoid disorders such as SLE, vascular syndrome, and other diseases such as Kawasaki disease, sarcoidosis, and the like. And arthritis may affect any number of joints, but the course is classically polyarticular in systemic onset GIA, and it might be very destructive, and it can include hip, cervical spine, and also temporomandibular joint involvement. Even though the arthritis type in systemic onset GIA is it can cause oligoarticular, but most of the time it is polyarticular, and it can involve any joint, including hip, cervical spine, and temporomandibular joint. This is the classic rash of the systemic onset juvenile diabetic arthritis, the evanescent salmon-colored lesion, which is macular and non-pruritic, and individual lesions are transient and occur in crops over the trunk and also the extremities. This one is rheumatoid nodules overlying bony prominency in adolescent with a rheumatoid factor positive polyarthritis. When we see the complication of systemic onset GIA, that is macrophage activation syndrome, this is a rare but potentially fatal complication of systemic onset GIA that can occur at any time. That means it can occur at the onset of the disease, during medication change, during active or remission phase of the disease course. It's also referred to as secondary hemophagocytic syndrome or hemophagocytic lymphohistiocytosis. There is increasing evidence that systemic onset GIA, macrophage activation syndrome, and hemophagocytic lymphohistiocytosis share similar functional defects in granule-dependent cytotoxic lymphocytic activity. In addition, systemic onset GIA-associated macrophage activation syndrome and hemophagocytic lymphohistiocytosis share genetic variants in approximately 35% of patients with systemic onset GIA macrophage activation syndrome. And the macrophage activation syndrome classically manifests as acute onset of high-speaking fever, lymphadenopathy, hepatosplenomegaly, and encephalopathy, and also laboratory evaluation shows thrombocytopenia and leukopenia with elevated liver enzymes, increased lactate dehydrogenase, ferritin, and also triglycerides. Patient may have purpura and mucosal bleeding as well as elevated fibrin split product values, and also prolonged prothrombin and partial thromboplastin time. The ESR falls because of hypofibrinogenemia and hepatic dysfunction, a feature useful in distinguishing mass from a flare of systemic disease. So, if there is a flare of systemic disease, there is increased in ESR. But if the clinical symptom is due to macrophage activation syndrome, there is a decrease in ESR because of hypofibrinogenemia and hepatic dysfunction. This is how we differentiate macrophage activation syndrome from a flare of systemic disease. An international consensus panel developed a set of classification criteria for systemic onset GIA associated macrophage activation syndrome, and they said we can diagnose macrophage activation syndrome in systemic onset GIA if there is serum ferritin greater than 684 nanogram per ml and any of the following two criteria: thrombocytopenia, elevated liver enzyme, hypertriglyceridemia, and hypofibrinogenemia. If we have two of four from this, 2 of 4, and elevated serum ferritin, we can diagnose macrophage activation syndrome in a child who have systemic onset GIA. When we see the laboratory findings in a patient with juvenile idiopathic arthritis, hematologic abnormalities often reflect the degree of systemic or articular inflammation with elevated WBC and also platelet counts, and the macrocytic anemia can be seen. Inflammation may also cause elevation in ESR and the C-reactive protein, although it's not unusual for both to be normal in children with GIA. Elevated ANA titers are present in 40 to 85% of children with oligoarticular or polyarticular GIA, but they are rare with systemic onset GIA. ANA seropositivity is associated with increased risk of chronic uveitis in GIA, and approximately 5 to 50% of patients with polyarticular GIA are seropositive for rheumatoid factor. anti-cyclic citrullinate peptide antibody, as with rheumatoid factor, is also a marker of more aggressive disease. Children with systemic onset GI usually have streaking elevation in inflammatory markers and the WBC and also platelet counts, and hemoglobin levels are too low. And also the ESR is usually high, except in the case of macrophage activation syndrome. Also, immunologic levels tend to be high. ANA and the rheumatoid factor are uncommon. This is a chronic anterior uveitis demonstrating posterior syncytia and absence of significant scleral inflammation. And in this eye, slit lamp examination shows flail in the fluid of anterior chamber caused by increased protein content, and also keratic precipitates on the posterior surface of the cornea, representing a small collection of inflammatory cells. Radiographic abnormalities, especially the X-ray. Early radiographic changes of arthritis include soft tissue swelling, periarticular osteopenia, and perosteal new bone apposition around affected joints. And continued active disease may lead to subchondral erosion, loss of cartilage, with varying degrees of bone destruction and also fusion. Characteristic radiographic changes in a cervical spine most frequently involves a neural arc joints at around C2 and C3. And it may progress. This is progression of joint destruction in a child with polyarticular juvenile idiopathic arthritis, and also a child who have rheumatoid factor positive, and despite dose of corticosteroids sufficient to suppress symptoms in the interval between the radiographs. The first radiography was taken at the beginning, and the second was taken 4 years later. It shows a loss of articular cartilage and the destructive changes in the distal and the proximal interphalangeal and also metacarpophalangeal joints, as well as destruction and the fusion of the wrist bones. Trantoaxial subluxation, and it might cause significant disastrous outcome. And MRI is more sensitive than radiography to detect earlier changes. When we see the diagnosis, GIA is a clinical diagnosis without any diagnostic laboratory tests, and the meticulous clinical exclusion of other diseases and the many mimics is therefore essential. And the laboratory studies, including the tests for ANA and the rheumatoid factor, they are only supportive or prognostic, and the results might not be. The results may be normal or abnormal in patients with GIA. So, determining ANA and rheumatoid factor are only to support the diagnosis or to classify good or bad prognostic sign. Otherwise, it has no diagnostic value. When we see the treatment of a child with GIA, the goal of treatment are to achieve disease remission, to prevent or halt joint damage, and also to foster normal growth and development. Management is directed according to disease subtype and the severity, and also presence of poor prognostic indicator, and also response to the initial medication. When we see children with oligoarthritis, the first line of therapy in children with oligoarthritis GIA is non-steroidal anti-inflammatory drug, for example, ibuprofen or meloxicam or naproxen. They are the first line. And if the first line treatment or non-steroidal anti-inflammatory drugs are not working, or if there is no or partial response after 4 to 6 weeks of treatment with non-steroidal anti-inflammatory drugs, or if they have functional limitation, for example, if they have leg length discrepancy or contracture, injection of intraarticular corticosteroids is recommended. We can give injection of intraarticular triamcinolone. And also if there is no response to non-steroidal anti-inflammatory drugs, and also if there is no response to injection of intraarticular corticosteroids, disease-modifying anti-rheumatic drugs, including methotrexate, can be given. When we give methotrexate, we should have to give also folic acid concomitantly, because methotrexate causes significant folate depletion, and it causes megaloblastic anemia, or it also causes other folic acid deficiency. Still, if there is no response to methotrexate, we can consider tumor necrosis factor inhibitor such as infliximab, IV every 4 to 8 weeks. So initially we try with non-steroidal anti-inflammatory drugs for 4 to 6 weeks. Then if there is no response, we will go to intra-articular corticosteroid injection. Still, if there is no response, we go to methotrexate or other disease-modifying anti-rheumatic drugs. And if there is still no response, we can go to tumor necrosis factor inhibitor. When we see polyarthritis or and also systemic onset GIA, non-steroidal anti-inflammatory drugs alone rarely induce remission in polyarthritis or systemic onset GIA. So we should have to give disease-modifying anti-rheumatic drugs. But most of the time, methotrexate requires up to 8 weeks for its activity to be seen, and during this period, we should have to give steroids concomitantly. So for 6 to 8 weeks, we will give methotrexate and prednisolone together, and after 6 weeks, we taper prednisolone and we'll continue methotrexate weekly. If there is no response to methotrexate, tumor necrosis factor alpha antagonists are used to treat children with inadequate response to methotrexate with a poor prognostic factor and also with severe disease onset. So in polyarthritis or in systemic onset GIA, we start with prednisolone with methotrexate for 4 to 6 weeks, 6 to 8 weeks overlap. Then we taper and discontinue prednisolone and we will continue with methotrexate with folic acid. And if there is no response to disease-modifying anti-rheumatic drug and the steroid, we will go to tumor necrosis factor alpha antagonists. Early aggressive therapy with a combination of methotrexate and the tumor necrosis alpha antagonists may result in earlier achievement of clinical inactive disease. And systemic corticosteroids are recommended only for management of severe systemic illness or for brief therapy during the wait for therapeutic response to a disease-modifying anti-rheumatic drug, and also for control of uveitis. And the management of GIA must also include periodic slit lamp ophthalmologic examination to monitor for asymptomatic uveitis, especially if they are ANA positive. And dietary evaluation and counseling to ensure appropriate calcium, vitamin D, protein, and caloric intake are important for children with GIA. And also physical therapy and occupational therapy are invaluably important to any treatment program. When we see the prognosis of a child with GIA, majority of children with a persistent oligoarticular disease achieve disease remission, and those with extended oligoarticular disease have poor prognosis. And also children with oligoarthritis, particularly girls who are ANA positive and with onset of arthritis before 6 years of age, they are at greater risk for development of chronic uveitis. So in a child who have oligoarticular GIA, if they have the poor prognostic signs are extended oligoarticular disease and also disease onset in less than 6 years of age, and also ANA positivity. Those are those are poor prognostic factors in oligoarticular GIA. There is no association between the activity and the severity of arthritis and the uveitis, and persistent uncontrolled anterior uveitis can cause posterior sciatica and also cataract, glaucoma, and band keratopathy with resultant blindness can seen. So early intervention is very important before the sign and symptom onset by periodic slit lamp examination. The child with polyarticular GIA often has a more prolonged course of active joint inflammation, and it requires early and aggressive therapy. And the predictors of severe and persistent disease in polyarticular GIA include young age at onset, rheumatoid factor seropositivity or rheumatoid nodules presence, and also presence of anticyclic citrullinate peptide antibody. And if there is many affected joints, and also if the disease involves the hip and the wrist joint, they are poor prognostic sign. And systemic GIA is often the most difficult to control in terms of both articular inflammation and the systemic manifestation. And poor prognosis in systemic onset GIA include polyarticular distribution of arthritis, fever lasting greater than 3 months, and also increased inflammatory markers such as platelet count and the ESR for more than 6 months. Orthopedic complications include leg discrepancy and flexion contracture, particularly of the knee, hip, and the wrist, can occur. And discrepancy in leg length can be managed with shoe lift to prevent scoliosis. And also joint contracture require aggressive medical control of arthritis, often in conjunction with intra-articular corticosteroid injection and appropriate splinting and stretching of the affected tendons. Thank you. And also don't forget to subscribe this channel.